in the rooms immediately before the exam, so we don't have any issues logging into Blackboard like we did last time. And your testing room will be posted around noon, I've been told, I think out on the wall out there, so you know which rooms to go into. Why do we have an echo? Why are we echoing? I don't know why we're echoing. My office hours for this week have been canceled. And if you're on Zoom, remember with the way that the computers and stuff are set up, we really can't see if you type something into the chat box. So please come off of mute if you have a question or if you want to contribute to the conversation or something. All right, I think that's all the announcements. Today, we're very, very lucky to have Dr. Amir Ali joining us. He is a clinical pharmacist specialist over at Norris, so just right across the quad there. And today, he's going to be telling us all about breast and prostate cancer therapeutic management. So thank you very much for joining us.
Just a little mic check. All right, if you guys can't hear me in the back, let me know. And if anyone on Zoom can't hear or see the slides, just unmute and let me know also. But I just wanted to start off first by thanking you all for joining today. I know you have a big midterm, and today I really don't want to overload you with knowledge. So we're just going to go through the basics of breast and prostate cancer. And I even want to touch upon some of the supportive care and therapeutics and chemotherapies that you'll also see potentially on your exam today, just to review some of those vital pieces of information. So bear with me today. And of course, if you have any questions, feel free to interrupt me at any time. So I do want to just introduce myself briefly. So as Dr. Burkhart said, I am a clinical pharmacist specialist in Hem-Onc at Norris, so right across the way over across the pharmacy school. I graduated from UCSF a couple years ago, did my first year residency at Kaiser Permanente in Orange County, and then completed my second year residency to specialize here at Norris, and then I just stayed on. My focus areas are actually mostly on the hematological side, so bone marrow transplant, emerging cellular therapeutics, CAR T cells, but nonetheless, a lot of my training was in oncological malignancies. So mostly breast and prostate cancer, those are huge areas of oncologic oncologic cancers, including lung cancer. So those are usually the top three oncologic disease states that you typically see on the solid cancer side. So before I start, I just want to disclose a couple things. So I do get consulting and speaking fees from a couple different pharmaceutical companies, but none of those companies make any breast or prostate cancer drugs, so really no conflicts there. So starting off with the first case. So on Blackboard, I posted a case, mostly that covers breast cancer. If you want to go ahead and download that, that will kind of go through just the SOAP note, essentially, patient information, the background, the disease states, and really just look over it. You probably haven't had a chance yet. Look over the case itself, and then we'll go into a couple questions, right? And talk about what are the risk factors for breast cancer? How do we manage breast cancer? How do we use supportive care for these patients? So the first half of the synchronous session today is going to focus on breast cancer, and the second half is really going to focus on prostate cancer. So I'll give you all about 10 minutes or so now, just to pull up the case, read through it, and we'll dive right into the questions. Does that sound okay for everyone? Yeah? All right. So yeah, let's go ahead and start off with that, 10 minutes. You guys need more time? I think you got it, right? Okay. So I wanted to start off by really asking you all here, how many of you know someone that has breast cancer or prostate cancer? Show of hands. So 4 or 5. So there's 6 people that raise their hand, and we're a room of like 8 people. So it's a very prevalent cancer. And if anyone minds sharing, what has your experience been like with those family members? What are they going through? How are they handling it? Are they doing okay? Does anyone want to share? Anyone on Zoom also can share also their experience if they're okay with it. No, it's a sensitive topic. So personally, I have 2 close relatives, almost immediate really, that have breast and prostate cancer. And in one case, both cases actually, it was things that I learned in pharmacy school that really helped them. So first case, I have an aunt with breast cancer. So she went in after she felt a lump on her breast. And originally she was thinking it was not a big deal. It's probably been there for a while. She just noticed it now. She went into her primary care, who essentially told her the same exact thing, just to monitor it. And she is one that is not very fond of our medical system here. So she doesn't like seeing doctors, not a huge fan of them. But I really pushed her to get a mammogram. And when she got it done, it showed a risk for potential malignancy. So when a mammogram result comes up, it'll either tell you, hey, this probably looks benign, non-cancerous, or hey, you should probably get this biopsied. So hers came up as potentially malignant. She got a biopsy done a couple weeks later, and it showed stage 1 breast cancer. Now, if she didn't go in, she waited a couple of years, and it started growing, this could have grown to stage 4. It could have metastasized. And so knowledge that you will gain today about risk factors, about diagnostics, about screening, can not only help your parents, patients, but really anyone you know. So same thing with prostate cancer, right? So oftentimes people confuse the symptoms of BPH, benign prostate hypertrophy, with prostate cancer. Very similar symptoms, right? So difficulty urinating, you have blood in the urine sometimes, urinary frequency, and so prevalence also increases with age. So same thing with both cancers. So this time it was a close relative who was just started on a medication for BPH without any digital rectal exam, PSA screening. So in this case, I told him, ask your provider to get a PSA, which is the blood test that can kind of help diagnose prostate cancer. So he was given meds for hypertrophy, and he improved, so he didn't think anything about it. I told him, get a PSA. He got a PSA from his primary care. It showed, does anyone know the normal PSA level? Less than 4. For him, it showed 90. So then he got screened, and it turned out he had stage 2 prostate cancer, right? So there's so many of these types of stories where you can play a huge role in your patient's care, right? And as I share these stories, I also want to mention, this can be a difficult topic. So, if you guys have any specific questions, even outside of this lecture, please feel free to ask. And a little side plug for oncology as a whole. It's a growing field, and anyone that's interested in oncology, whether it's clinical, whether you want to go into industry with an oncology focus, as I said on Blackboard, feel free to reach out. So starting off with case 1, we have a patient DV that you just read about, and she has breast cancer now. And the question is, what were her risk factors for breast cancer? And I ask you this because my aunt had risk factors for breast cancer. So that's what got me thinking. If her primary care thought about these risk factors, then he probably could have considered urging her to get a mammogram and taking it a little more aggressive in terms of her treatment and diagnostics. So does anyone have any thoughts on her risk factors for breast cancer? Anyone on Zoom or anyone in the room? Yes? Perfect. Yeah, you got it. Sorry, what was your name? Danny. Thank you, Danny. So Danny just hit the key points there. He got pretty much all of them. So obviously, female gender. So breast cancer can occur in males and females. Prevalence-wise, obviously, you're higher risk if you're female. Early menarche, so that's what the patient had. She had her first child when she was greater than the age of 30, which is a risk factor. Alcohol use, this one's one that we don't consider that often, but definitely a risk factor. And then family history. So my aunt hit 3 of these risk factors. And so, that's what really got me thinking. And then there's also a genetic component, which this patient doesn't have. Does anyone know the genetic component of breast cancer? Very prevalent. BRCA1 and 2. That's a gene that increases risk of breast cancer and prostate cancer, right? So whenever you have a family history of breast cancer, I encourage you to get tested for that mutation, because people with that mutation are at a huge risk of getting breast cancer. It's probably one of the most notable oncogenes out there for any malignancy. So, if you have a family history, immediate family history, definitely get tested for this gene, because there are things you can do to prevent risk of breast cancer. All right. Next question. So, what factors must be taken into consideration when determining treatment options for DV's breast cancer? So I want you guys to think about it. I'm not going to ask for an answer right away. So a couple things to think about is, how do we treat breast cancer to begin with? What receptors do we look at? Does estrogen play a role in our treatments? What receptors play a role? Comorbidities, what those, how those play a role in treating breast cancer. So there's a lot of different pieces. So whenever I get consulted for a patient, right, these are all things I think about, because you will be asked this, even on the NAPLEX. So you can't just name any kind of therapy and give that to every single patient. There are specific treatments designed for certain patients. So take some time, maybe 5 minutes or so, to think about these, and then we'll discuss them. Okay. Does anyone on Zoom have any thoughts on this case or this question? Any considerations? All right, what about anyone in the room? Yeah. The receptor status, and what was the second one? Menopausal status, yeah. If the patient's pre or post menopause. That's a good one. Any other thoughts? What about specific receptors besides hormonal status? What receptors on cells, breast cancer cells? ER and PR, so estrogen and progesterone. So those are definitely, the hormonal receptors. HER2, yep, that's an oncogene. That's a receptor on cells also, so we can have specific therapeutics that target them. And in general, that brings up a good point. In general, patients who are HER2 positive have worse prognosis. So, but we do have targeted therapies for it. So if a patient's HER2 positive, then we have therapies to target it specifically. What else besides that? Comorbidities, yeah. So any comorbidities that you have in mind that might change our treatment decisions? Yeah, good catch. We have 2 drugs that can play a role in worsening cardiac function. So anyone know what those 2 drugs are? One I think you've learned before. Trastuzumab, that one's specific for breast cancer, yeah. There's also a chemotherapy. Anthracyclines, yeah. So those are used in a lot of cancers. So, you've probably had a couple lectures already that you've been able to see anthracyclines in. So, yes, anthracyclines. The main difference between those 2 in terms of their cardiotoxicity is anthracyclines cause permanent cardiotoxicity, while trastuzumab, Herceptin brand name, can cause temporary, reversible cardiotoxicity. Right? So a patient with heart failure already or a low ejection fraction, you might want to be a little more cautious about starting them on a medication that can make it worse. Right? So when I'm assessing a patient, I'll ask for a baseline echo, and I'll look at their ejection fraction. And if it's low, I'll stay away from those types of therapies. Right? Another thing is renal function. So certain chemotherapies, certain therapeutics are excreted in the urine. And if the urine function is poor, you might not want to use it in those patients because the chemotherapy can build up. There's also meds that are nephrotoxic. So you don't want to push them from chronic kidney disease to dialysis, right? So, you have to be cautious about all of these different treatment options for these patients. So what I have here is a couple other things. So one being what stage the patient's in, right? So that's important. So depending on the stage, you're going to treat the patient in different ways. You're going to treat a stage 1 patient very different than you're going to treat a stage 4 patient, right? Very different therapeutics. You look at the labeling for a lot of our drugs, it'll specify, do you use this for early treatment of breast cancer? Do you use this for metastatic, stage 4 breast cancer? So depending on the stage, you'll have different therapeutic options. Tumor size and lymph node involvement. So certain drugs, for example, Perjeta, which is also targeted at HER2, so you have trastuzumab and pertuzumab. Pertuzumab, you typically would add on to trastuzumab if there is lymph node involvement. So that also plays a role. Lymph node involvement can definitely play a role. Also taxanes, a lot of times you add taxanes if there is lymph node involvement. So we mentioned ER-PR status. So if a patient is ER-PR positive, we can use our hormonal agents, right? So we'll block estrogen. We can use tamoxifen. We can use aromatase inhibitors. We have a whole slew of options for these patients, right? But if they are not ER-PR positive, not only does it equal worse prognosis, but you also cannot use those therapies on them. So you're getting essentially ER-PR negativity means that the breast cancer is not growing due to estrogen or progesterone. It's growing due to other factors. So you cannot use those types of therapies for those patients. So ER negative, PR negative, HER2 positive is the worst prognosis. ER-PR positive has a better prognosis because you have more therapies, and if the cancer is dependent on estrogen, you can block estrogen, right? So it's an easy way to target the breast cancer cells. BRCA. Okay, so you might be wondering, okay, so that's a risk factor. Why does it play a role in therapeutics? So we have specific drugs that can target that mutation, right? So we have olaparib, for example, is a BRCA-specific drug. You can also see it in prostate cancer as well. So if a patient has that mutation, you can use it. So the thing is with these agents is they're typically used in the later stages. So typically you won't see BRCA drugs used until stage 4 breast cancer. And it's indicated for use in hormone receptor positive patients, HER2 negative patients that have the BRCA mutation. So that's when you would see that. And we talked about comorbidities and then patient performance status, right? So I'm going to treat someone that's a healthy young 30-year-old very differently than an 85-year-old patient that comes that's on a ventilator. So, you're not going to treat them the same. One probably is not going to be able to handle chemotherapy, and one might do really well with chemotherapy, right? So all of these factors will play a role in coming up with treatment recommendations. And these factors are, besides like the hormone stuff, they're not specific to breast cancer. They're really any type of cancer, you'd think about these things, right? So receptors, we have precision medicine now. We can target specific mutations. You look at lung cancer I know you're studying right now, there are so many specific mutations you can target with lung cancer. Breast, unfortunately, not as much, but you still have that over there. So you think about these same things with lung cancer. You think about the same things with any type of cancer, right? So just keep that in mind. And then, by the way, throughout these cases, so you'll have a quiz at the end of this. That's part of the deliverable. If you see anything bolded, just focus on that, just for your reference. But there's nothing bolded on this slide. Okay, so let's move on to the next one. So the question is, what patient-related objective information is needed to safely proceed with DV's planned doxorubicin? So doxorubicin is the type of chemotherapy. And then, there's a lot of different safety pieces associated with doxorubicin. Very testable, can show up in really any exam because it's used a lot in different cancers. So take a minute, review your notes on doxorubicin, and then we'll go ahead and discuss it. Okay, so does anyone on Zoom have any thoughts about this question? What objective information is needed? And by the way, I can almost guarantee you'll have a question about doxorubicin today. So this is good review. Okay. Anyone in the room have any thoughts about this question? Go ahead. Yeah. Exactly. Yeah, those are two important pieces when looking at doxorubicin. Any other thoughts? Yeah. Yeah, and that really piggybacks off the lifetime dose because, if we exceed that, that increases risk of worsening ejection fraction, even more so than what's the baseline risk for doxorubicin. Anyone else have any thoughts about it? Go ahead. Heart rhythm. It is cardiotoxic. Yeah, so that's always good to keep in mind. All right. So let me show you what I have. So first thing to mention is here's a story for you. So I was a resident, and I had a patient that was starting the AC regimen for breast cancer. So AC is the anthracycline, which is doxorubicin in this case, and C is Cytoxan, cyclophosphamide. And I had to go counsel her on her chemotherapy. And it was actually not her first day on the therapy. She had it like one cycle before I spoke to her. And typically we try to speak to the patients on their first cycle so they know what to expect. But in this case, for some reason, they did not counsel the patient the first cycle, very extensively at least. So the first thing she said to me, even before I started counseling, is, I'm sweating red and my urine's red. And I don't think that's normal, and I think I need to go to the emergency department. And so what do you guys think about that? How do you respond? It's a side effect, yeah. Yeah, so it's expected, right? So if you don't tell these patients what to expect, that can be scary. Can you imagine just starting to sweat red? I mean, that seems a little concerning. So it's very important to talk about the discoloration of sweat, of urine, of any bodily fluid as a result of doxorubicin. So just keep that in mind. Really, the next thing is talking about the cumulative dose and ejection fraction. So the range differs in terms of cumulative dose. There's not an exact number that I can just point you to, but in general, most institutions consider a lifetime dose to be completed around 450 to 550 milligrams per meter squared. And keep in mind the milligrams per meter squared. It's not just milligrams, because people definitely go over that milligram level. Milligrams per meter squared. And so once you pass that number, your risk of cardiotoxicity goes up much higher than when you're below that number, right? So that's how we came up with the lifetime limits. And so, we do need to monitor these patients continuously to see how they're doing in terms of their ejection fraction. So when a patient's on trastuzumab, when they're on doxorubicin, we typically will get an echo to check their ejection fraction every 3 months or so, right? Could be a little early, could be a little late, but on average, every 3 months. And if we're noticing changes, let's say from baseline, their ejection fraction decreased for more than 15%, we typically will dose reduce the chemotherapy or even hold it in severe cases. So, we do have to monitor these for patients because you want to give these patients a drug that can potentially cure them or prolong their life, but also you don't want to kill them on the other hand just from cardiotoxicity. So there's a delicate balance for chemotherapy between efficacy and safety, right? So you always have to keep that in mind for patients with breast cancer. So our patient specifically, DV, she is getting a doxorubicin dose of 60 milligrams per meter squared. And she's gotten 2 doses, right? So that means her lifetime dose as of now is 120 milligrams per meter squared. Right? So she is below the lifetime level. So in that case, we can proceed. Her ejection fraction is fine. No issues. And 65% LVEF. Does anyone know what number, is that a good LVEF? Is that low? What do you guys think about that number? Kind of higher than normal? Average? Okay. Yeah. So this is a normal ejection fraction. So I would be more concerned if the number falls below 45, 40, then you'll be a little more concerned in that case, right? So what is something we can do? It's on this slide and it's bolded. What is something we can do for patients that are getting close to the lifetime dose? Dexrazoxane. So dexrazoxane is not a chemotherapy. It's an agent that helps control the free radicals that is caused by doxorubicin. So one of the mechanisms of doxorubicin, or any anthracycline, is creating these free radicals, right? These free radicals can cause the cardiomyopathy. So dexrazoxane can help control that. So if a patient is getting close to the lifetime dose, then we can use this agent. And there are 2 brand names for this, and each brand name is used for a different indication. One brand name, Zinacard, is used for patients like this, where if not this patient specifically, but if they're close to the lifetime dose, we can use that. There's also a brand name of Totect, which is used for extravasation. So extravasation is when, let's say you're giving the chemotherapy peripherally or central line, and the line moves, the patient's walking around or something, and the chemotherapy starts going into the tissue, into the muscles, right? That can cause huge necrotizing tissues and can really destroy the muscles, ligaments in that area. So what you can do is really neutralize it with using dexrazoxane as well. We actually had a patient about a week ago at Norris that had extravasation. So what happened was they were very active while getting the chemotherapy infusion. So they were like walking around, maybe a little too active, and the line moved. And they started noticing just some swelling, right? Some swelling. And when a way you can check to see if there's extravasation is seeing if there's blood return. Nurses can check this, right? So if there is no blood return, when you, let's say you put a syringe, attach a syringe and pull, if there's no blood return, that means you're not in the vein, right? So that means the line was not in the vein and the chemotherapy was going into the surrounding tissue. So first thing you do, stop the chemotherapy, put some ice on it, and then you consider the use of dexrazoxane. So very useful and definitely something to keep in mind for these patients. One important note for anthracyclines, just for your own knowledge purposes and to help prepare you for any exam, is any anthracycline can cause cardiotoxicity, not just doxorubicin. So just keep that in mind. So there are other anthracyclines that can cause the same thing. So daunorubicin, mitoxantrone, they all can cause similar types of toxicities. So it's not universally just doxorubicin that causes this. Anyone have any questions about this slide? Straightforward. This is probably the most interesting and convoluted chemotherapy there is, doxorubicin. There's a lot of counseling points, a lot of monitoring associated with it. But it's definitely one that's I think I had maybe 2 questions on it on the NAPLEX. So one to keep in mind just for your boards. Definitely an important chemotherapy. Let's see, is there anything I missed? No, I think that covers it. Okay. That note on the bottom too is also bolded. So trastuzumab also requires LVEF monitoring, since we talked about that can also cause cardiomyopathy, but it's reversible. All right, so here's the next question. So what side effects or toxicities of DV's specific chemotherapy or hormonal therapy regimen do you want to counsel her on? So I guess she's on hormonal therapy, and she's also getting doxorubicin and Cytoxan and maybe trastuzumab. So, you're assigned to go talk to this patient, just like I was. What would you talk to this patient about? How do you prepare them for the chemotherapy? So take about 5 minutes or so, think about it, and then we'll go ahead and discuss. go ahead and discuss this one. So does anyone on Zoom have any thoughts? How do you counsel this patient? I'm really hoping by the end we'll have one person on Zoom respond. That's okay. Anyone in this room have any thoughts? Yeah. Yeah. That's the number one thing. Yeah, if you forget to counsel on that, things can go bad. You can lead the patient to the emergency department just if you miss that counseling point. Yeah. What else? Alopecia, yeah. Especially Cytoxin. Cytoxin causes a lot of alopecia. So what do you tell them about that? I mean, you just tell them their hair is going to fall off and never come back, or what do you tell them? Exactly. So it's a temporary thing. So what does chemotherapy do? Right? Basic question. What does chemotherapy do? Does it hit the cancer cells specifically? No. It hits all types of cancers. All types of cells. And the most important thing is to realize that chemotherapy often first targets the fast-dividing cells, cells that are dividing rapidly. So what's dividing rapidly in your body? Follicles, skin cells, also guts, cells in your gut. So you can get that GI side effects. You can get hair loss, right? Mucositis, right? Because of the cells in your mouth and your esophagus. So that's a side effect, right? And it doesn't mean those cells are not going to come back. They'll come back eventually. It can take some time. But the main thing with hair loss is that, yes, it'll come back, but texture can change, right? Color, texture can change afterwards. So what I do with my patients is the first floor of Norris, if you guys walk in there, there's a wig shop. So patients will get their chemotherapy. Oftentimes when their hair starts falling off, it doesn't fall off like the day of the chemotherapy. It's not just going to suddenly fall off. It takes time. So it's like when they're showering, they'll notice more hair coming off. And eventually, they'll have these bald spots. And what most elect to do is just to shave it off and go with the wig. There's some really cool color wigs out there. We have like pink ones, whatever color you want. So sometimes I'll walk them to the wig store when their hair starts falling off, and we'll pick out a wig together. So that's something you can do. All right, what else? Yeah. Yeah, exactly. Yeah. So that's like an excellent counseling point when they're there getting the infusion, because we all know what just happened to that last patient, right? So be careful. Don't move around too much. Of course, go to the bathroom, walk around, but just be careful. And if you're noticing any pain, any redness, any itching in that area, let your nurse know right away. They'll call over the pharmacist, and we'll make an assessment of what to do. What else? Yeah. Yeah. So hormonal therapy is not fun, right? So there's a lot of side effects associated with shutting off your estrogen, right? So hot flashes, mood changes, you're right. It also can increase your risk of cardiovascular diseases, osteoporosis when you're taking away estrogen. So really all the counseling points, like be careful, don't, go on these like extreme snowboarding trips, you got to be cautious. And also, you bring up a good point about just hormonal therapies in general. they're not really class specific. So you'll have a lot of the same hormonal therapy effects, whether you're using tamoxifen, aromatase inhibitors, and even the same things in the prostate cancer module. So you'll see similar side effects with those. Any other ones? So for doxorubicin, we know it causes cardiotoxicity. So what do you counsel a patient? Like how, you tell them that and they'll just look at you with a blank stare. They'll be like, okay, so what am I supposed to do? You have to tell them what symptoms to look for, right? What would the symptoms be of lower EF? What are the symptoms of heart failure? Fluid retention, shortness of breath. So you tell them if they're experiencing these things, let us know. We'll do another echo to see what's going on. Sometimes these things can escalate. You go from 1 month having perfect EF, next month it drops 15%, so you got to be careful. All right, let's see what else we have. So the discoloration is bolded over there for doxorubicin, symptoms of heart failure. Cytoxin, we talked about the alopecia, also counseling them on using gentle shampoos, a soft brush will help protect your hair, right? So, it's probably going to fall off anyway, but there's some things you can do to prolong that from happening or delay it. And then she's also getting Taxol, which we didn't talk about. So the biggest thing with Taxol is really two things. One is hypersensitivity, which happens right away, or it can be slightly delayed. So letting them know, hey, you're going to get this infusion. If you're having any symptoms of anaphylaxis, and you go through that, of course, please let us know. And the reactions with Taxol are somewhat interesting. Not everyone has these typical shortness of breath, hypotension type reactions. So sometimes a patient will just get back pain, arthralgias, and that's actually a hypersensitivity reaction to Taxol. So these things you have to monitor for and keep in mind. And then neuropathy. So that's big. I don't know if you guys have ever felt neuropathy, but if you sit on your hand for 5 minutes and you get off of it and it's all tingly, imagine having that for a week, just that feeling a week. So it's not a fun feeling, and you want to let patients know, if they're experiencing something like that, to let us know. There's things we can do. One is we address it with meds, so you give them gabapentin, Lyrica, and also you dose reduce, because you're trying to cure the patient, but at the same time you don't want to lower their quality of life that much, right? So keep that in mind. The cold or hot, if they're washing dishes or in the shower, cold or hot water can exacerbate the neuropathy associated with Taxol. Tamoxifen, we talked about hot flashes, night sweats, and there's also vaginal dryness and thrombosis risk. So tamoxifen increases risk of DVT. So, counsel patients on risk factors. Not only risk factors, but signs and symptoms of a DVT, right? Swelling in the legs, red leg, if they're in a plane for 12 hours, walk around, things like that. And, things that you can do for hot flashes. One of the biggest things is tell them to wear layers. So if they get hot, they remove them. Loose-fitting clothing. There often is a question about what else can you do for hot flashes? So there's a lot of things out there. You go to Trader Joe's, you'll find these types of things. Soy, these herbal supplements. The issue with those is they contain phytoestrogens. So you don't want to give them to people with breast cancer because you don't want to give them estrogen. You're trying to block estrogen, but a lot of the things that help with hot flashes have estrogen in them. So you always have to counsel them, hey, don't take these over-the-counter things, herbal stuff, because, they probably have estrogen in them. That's why it's helping with your hot flashes. And then that's essentially it. Any questions about the counseling points on this slide? No? Okay. How about this? Let's take like a 5-minute break. If you guys want to go to the restroom, stretch out, and then we'll reconvene after that. All right, welcome back, everyone. So, we're going to dive into prostate cancer now. So, I don't know, out of those handful that raised their hand when I asked that first question about how many people know someone with breast or prostate cancer, how many of you know someone with prostate cancer specifically? 1, 2. Okay, so a little less than breast cancer. So, prostate cancer is a very common cancer, actually. So I mentioned in the asynchronous lecture that, once you pass the age, once men pass the age of 65, 70, their risk of prostate cancer is very high. And so there's a lot of patients that, develop prostate cancer during that age range. And something unique about it is it's a very slow-growing cancer. I'm not saying if you have prostate cancer, there's nothing to worry about. But what I am saying is it is slow-growing, and oftentimes when someone gets prostate cancer, especially later in life, let's say 60s, they're more likely to die from non-prostate cancer-related things than prostate cancer, right? So even to a point where if a patient is greater than 75 years old, we don't even, like, if we're worried about prostate cancer from an exam or just his symptoms, we're not even going to biopsy it. We're not going to do anything for the most part, let's say 90% of cases. Just because odds are this 75-year-old male is probably going to die from a heart attack, from a stroke, sorry to be so blunt, prior to prostate cancer, right? So keep that in mind. But at the same time, prostate cancer can sometimes surprise us, start in younger males. So, it can progress over time and become metastatic in that case too. So definitely a cancer that's important to treat and to monitor for. So now we have case 2. So this is JJ. There's no, by the way, there's no handout associated with this case. So it's JJ is a 68-year-old African-American male presenting to his PCP for a regular checkup. His younger brother, LJ, was recently diagnosed with prostate cancer and encouraged JJ to get screened for prostate cancer. JJ has a BMI of 26 and often eats fast food. So the first part is, what risk factors does JJ have for developing prostate cancer? Anyone on Zoom have any thoughts? What are his risk factors?
Family history.
Family history, that's right. Anything else besides family history? So this is what I have. So African Americans are at a higher risk factor group, race-wise, for developing prostate cancer, and this is an African American male. And family history is there. Age, as you increase in age, your risk increases proportionally. So age is there as well. And diet. Diet plays a role. So lots of red meat, fatty diets have been associated with an increased risk as well. Obesity is also there. I honestly wouldn't classify him as obese with a BMI of 6, but obesity is a risk factor. So next question is, are there any tests that you would recommend for JJ? So JJ wants to be screened. So I mentioned one test already during the first 5 minutes. Is there anything you'd recommend? PSA? Yeah. What about a physical test? What can they do? Digital rectal exam. Yeah. So that's it. You can see PSA is bolded there. So those are really the two main things in terms of just not really diagnosing, but confirming if there is something there. So if a patient has risk factors, maybe they're complaining of a couple symptoms, you can pull a PSA, and that can tell you something. You can also do a digital rectal exam. So that's the test that a lot of males are afraid of when they go to the doctor's office, especially older males. So, but that is a test that you can do. And essentially what you're doing is the physician or any provider would feel for the prostate and look for any lumps, anything abnormal. And that digital rectal exam can lead them to say, hey, I feel something, let's get a PSA, or hey, let me refer you to some imaging and potentially see what's going on over here. Okay. Oops. So, and the last question on this slide is, what about JJ's 78-year-old brother, AJ? Are there any tests you recommend for him? So he does have a family history now, first-degree family history of prostate cancer. This is a 78-year-old male. What do you think we should do with him? That's right. Sorry, what was your name? Jeffrey. So Jeffrey said he's greater than the age of 75. So odds are, there's really not much we can do in that case regardless. So there's really no general consensus on screening recommendations for patients greater than 75 years old. But hey, if this is a 75-year-old or 78-year-old that's, running marathons, healthy, no medical issues, go ahead. He can live to 100, get him screened. If this is a 78-year-old male that has heart failure, that has a bunch of comorbidities, ECOG score that's 3 or 4, then, it's probably not worth or the best interest of the patient to get a test. Because let's say the patient does have prostate cancer, right? So what are you going to do? First, you have to get a biopsy. A biopsy is very invasive. A biopsy for prostate cancer can lead to not having any control of your urine. So let's say they hit the wrong spot or the biopsy does not go that well. There is cases of leakage. So that's not ideal, right? And let's say they find prostate cancer for a 78-year-old male with a poor prognosis. Are you going to put them on chemotherapy? Can this person tolerate chemotherapy? Can they tolerate hormonal therapy? It depends, but most of the time the answer is no for this age group. All right. So here's the next question. So NF is a 60-year-old male who receives his biennial PSA screening. His labs show a PSA of 11, and biopsy confirms adenocarcinoma, Gleason score of 7. T2B intermediate risk. So NF received an external beam radiation, that's his first therapy, followed by ADT, or androgen deprivation therapy, with leuprolide for 6 months. So the question is, provide 4 patient counseling points for NF regarding leuprolide. So leuprolide is a form of ADT. So essentially, you're blocking upstream pathways of testosterone production, right? So whether you're using an antagonist or an agonist, in this case it's an agonist on the receptor, and eventually you're going to decrease production of testosterone. So that's what's called the androgen deprivation therapy. So it's one of our most common used medications for androgen deprivation therapy, and it's given not that frequently, so it's very easy for the patients to get either IM or sub-Q, given either monthly, and there's formulations for 3 months, 6 months. So there's different formulations that makes it even easier for patients. But that being said, it's a very effective medication, but then it has side effects associated with it. And we need to discuss counseling points for these patients. So does anyone have any thoughts about what we would counsel a patient when they're starting gluprolide? So let's go into it. So first thing I mentioned, it can be given IM or sub-Q, and the formulation will help determine how often you give it. So different dosages require different times of administration. Most common one I have on this slide, 1 or 3 months, is typically the go-to, the one that most insurances would cover. I mean, you tell them what it does, right? So we talked about this. So it will reduce testosterone levels in the body, which in turn, for prostate cancer, will decrease the growth of prostate cancer. So for the most part, prostate cancer is growing due to testosterone, right? Especially like earlier stages. And when you're stopping or suppressing testosterone, you're going to limit the growth of the prostate cancer. So you tell them what it's doing and why they need this medication, right? And the symptoms side effects are very similar to the ones we saw in breast cancer, right? So when you're blocking these hormones, a lot of these symptoms are the same. So they're going to have hot flashes in males, headaches, fatigue, hair loss even, decreased libido, changes in their sexual functions, and then just from the med purely infusion site reactions or injection site reactions. And the same thing with tamoxifen, with aromatase inhibitors from breast cancer. There are long-term side effects. So when you're blocking these hormones, you increase risk of CVD. So hypertension, diabetes can be increased in these patients, and also osteoporosis. So oftentimes you'll recommend patients be on vitamin D, calcium to help really prevent that risk or address it. Any questions on this slide? No? Okay. So pretty much the same patient, and it's associated with leuprolide. So what are monitoring parameters? So we're saying these are the side effects. This is what the drug is doing. How do we monitor for safety for this patient and also efficacy? How do we know if the drug is working, right? What do we do to see if the drug is working? Does anyone have any thoughts on that? Yeah. Perfect. Yeah, very comprehensive. Nice job. So you pretty much mentioned everything on this slide. So PSA level, right? So check their PSA. If their prostate cancer is improving, you'd expect to see a decrease in their PSA levels, right? Because PSA is specific to the prostate, and if you're seeing a shrinkage of the prostate, you should see the PSA starting to go down. Testosterone level, right? So you want to see if the drug is working. And how is the drug working? You look at the testosterone levels. So, you want that number to be less than 50. So if the drug is working, you test testosterone. If it's below 50, you know that the drug is working. In some cases, you can see patients that are on this therapy, but their testosterone is not that suppressed. So you need to add different kinds of therapies, little receptor blockers, things like that, if they're not responding too much to the leuprolide. Tumor size, and their symptoms. So let's say the patient came in with difficulty urinating. So one thing you can easily check for efficacy is if that's improving. Prostate's probably shrinking, right? So that's something you look at for efficacy. And then safety, it's a lot of the CVD stuff. So, I mean, nothing very specific. You'll check for diabetes, check their A1C often, every 3 months or so, every 6 months. Cardiovascular risk, so check their blood pressure, EKG changes. Osteoporosis, you do the bone scan, DEXA scan, see if they need any medications for the osteoporosis, or you can just supplement with calcium and vitamin D if it's, not bad. And then tumor flare. So does anyone know what tumor flare is? So whenever you start LHRH agonist therapies, an agonist will, just by definition, increase production of the testosterone in the cycle, right? So in the beginning, you're getting increased level of testosterone production, which sounds counterintuitive. Why would you give an agonist to increase production of testosterone? It sounds weird, right? But eventually, when you keep the agonist on, it eventually causes a feedback loop that decreases production of testosterone eventually. So in the beginning, you can see more testosterone, but after a couple weeks, the testosterone levels will start to fall. So tumor flare is for the first couple weeks, your symptoms can flare up because all of a sudden you're getting more testosterone, which is counterintuitive. So you can get worsening symptoms. So urinary obstruction can get worse. And then, the bone pain and cord compression, those are unique factors in terms of, let's say the prostate is really growing very large and it's getting close to the spinal cord. You can have symptoms there. Bone pain, that's essentially meaning if the cancer has metastasized to different parts of the body, specifically the bone, and you're giving more testosterone there, that would cause bone pain because it would be growth of a tumor in a bone, right? So those are specific factors. So provide 3 counseling points specifically to NF of why he should take bicalutamide prescription along with his leuprolide. So bicalutamide. So you're not giving leuprolide by itself in the beginning. You're giving bicalutamide with it. Does anyone know why you'd give bicalutamide in the beginning with leuprolide? Yes. Exactly. So the answer was to reduce symptoms of tumor flare. So I just mentioned that last piece about tumor flare. So you want to avoid the symptoms of tumor flare, and you want to protect the patient from the cancer getting worse. So what I didn't mention on the last slide is that there's something you can do about the tumor flare. And the thing that you can do about it is give another drug with it that blocks the receptors of testosterone. So by itself, bicalutamide is not an effective drug. I'm not going to give a patient bicalutamide by itself and hope their cancer goes away. It's not that effective. But when you use it, you can use it with leuprolide to prevent the tumor flare. So we talked about tumor flare. So it says, the leuprolide initially increases testosterone before decreasing it. So that's what you tell the patient. And therefore, testosterone can first stimulate cancer cells and cause more symptoms. So there is a medication called bicalutamide that inhibits testosterone from binding to the prostate cancer cells. And again, it's not used for monotherapy. The dose is listed on that slide. And you're not going to continue this for lifelong, right? You only want to use it for when the tumor flare risk is there. So we recommend giving it to the patient 7 days prior to starting the ADT. So we started a week before and we continue for about 2 weeks after the ADT starts. And at that point, you give a 3-week supply. After that, they don't need to take it anymore. They just keep on the injections every 1 month or 3 months is the usual. Okay. So what are some monitoring parameters? So pretty much very similar question, but what kind of labs, what kind of parameters would you monitor for patients on ADT? Because it's very common. So like we have so many patients on these therapies, you need to know kind of what to look for. Whether even if you're verifying these injections outpatient or you're an oncology pharmacist yourself, you kind of have to know, okay, what should I look for? Is this safe for the patient to get another dose of this therapy? So what do you guys think? So a couple things here. So the CVD risk factors are there. So blood pressure, blood glucose. There's a couple of things I didn't mention yet, but I have on this slide now. So this med can cause hypokalemia, so you definitely check the CMP, serum K. LFT, so it can cause some hepatic abnormalities, so checking liver function. And then other side effects to look out for are listed in the parentheses. Not very common, but if a patient experiences them, they're probably from the ADT. So that concludes the synchronous portion. Does anyone have any questions regarding this information? Okay. So I know maybe a lot of you were not fully engaged in this, and it's understandable. So if you listen to this later on, it's going to be posted online. Just review it. A lot of this information could show up in the final exam, so just make sure you review what we talked about today along with the asynchronous portion. And if you have any questions, you can email me. And again, if you're ever interested in talking more about oncology pharmacy or even want to shadow me one day in the clinic right across the street, please feel free to email me. We can set something up. And that's about it. Good luck on the exam today.